My name is Dr. Chandrima Pramanik. I am pursuing a fellowship in critical care at Asian Reliance Foundation Hospital. And today I'm going to speak on applied physiochemical principles of renal replacement therapy. First of all, what is renal replacement therapy? It is a modality of treatment which helps in three purposes. It helps in removal of toxic metabolites from the body, corrects blood electrolyte composition by means of an exchange between patient's blood and dialyzer fluid, and it also removes excess fluid from the body. So the principles of dialysis is that there is a semi-permeable membrane which separates the blood compartment from the dialysate compartment, and there is transfer of solutes across this membrane to and back and forth till they reach the equilibrium. So there are some principles which are related to solute removal, which are diffusion and convection, and there is a principle related to water removal, which is ultrafiltration, which follows the convective pathway. So what is diffusion? Diffusion is a process by which solute molecules move from an area of higher concentration to an area of lower concentration across a semi-permeable membrane. Now, diffusion can be ordinary or forced. If it is an ordinary diffusion, it is caused by random molecular motion. But if it is forced, then it is caused by an external force acting upon it. So the factors which are affecting diffusion are: one is the concentration gradient. With increase in the concentration gradient, the rate of diffusion increases. Second one is the surface area of dialyzer and its efficiency. Each type of dialyzer has a different diffusive capacity, and it also affects the rate of diffusion. Third one is molecular weight of solutes. Now, as we see, small solutes, they diffuse easily through the semi-permeable membrane, whereas the larger the molecular weight of the solute, the slower is the rate of diffusion. So in order to maintain this rate of diffusion, hemodialysis utilizes a counter current flow where the dialysate is always flowing in the opposite direction to the blood flow in the extracorporeal circuit. And this counter current flow is responsible for maintaining the concentration gradient across the membrane and thus increases the efficacy of the dialysis. Next is convection. Now, what is convection? Convection is the simultaneous transport of solvent and solute from blood compartment to the dialysate compartment across the dialysis membrane. So here the semi-permeable membrane, it acts as a sieve. And through this semi-permeable membrane, the water molecules, since they are extremely small, they can pass through the sieves of the semi-permeable membrane. And with these water molecules, some amount of solutes, which are small and medium-sized molecules, they can easily pass through the membrane pores. And this process is called a solvent drag. Larger solutes, especially those that are larger than the membrane size, membrane pore size, they are left back. This is a diagrammatic representation of diffusion and convection. So here, if we see in the diagram, diffusion is driven by concentration gradient. So here there is a concentration gradient which is maintained, and because of this concentration gradient, the low molecular weight solutes can go from the blood compartment to the dialysate compartment. On the other hand, if you look at the convection, we will see that there is a semi-permeable membrane and there is a high transmembrane pressure. So this is driven by the pressure gradient, and from here blood, the small molecular size as well as the middle molecular size particles move from the blood to the dialysate because of convection. Next is ultrafiltration. Now, ultrafiltration is a process by which water moves from a compartment of high pressure to low pressure across the semi-permeable membrane. So ultrafiltration is also governed by two factors. One is the transmembrane pressure. Now, because of this transmembrane pressure, water along with small solutes move from the blood to the dialysate in the dialyzer. And the rate of ultrafiltration usually depends on the total pressure difference. The pressure difference in between the blood compartment and the dialysis compartment. Second one is the ultrafiltration coefficient, which refers to the permeability of the dialyzer membrane to water. Now, it depends on the membrane thickness and pore size also. Ultrafiltration coefficient is usually defined as the number of milliliters of fluid per hour that will be transferred across the membrane per millimeter mercury pressure gradient of the membrane. So if we apply these principles to different forms of dialysis, hemodialysis usually refers to the process of diffusion, wherein the small molecular weight size solutes get transferred from the blood compartment to the dialysis compartment across the semi-permeable membrane. So intermittent hemodialysis refers to diffusion, whereas if we compare it with the CRRT, so CRRT has 4 different modalities. One is the SCUF, which is slow continuous ultrafiltration. This modality helps in fluid removal only, and hence it is based on the principle of ultrafiltration. Whereas continuous veno-venous hemofiltration, it helps in removal of solute, small and middle-sized molecules, and it is based on the principle of convection. Next is continuous veno-venous hemodialysis. It helps in removal of small molecular sized solutes, and it is based on the principle of diffusion. Whereas continuous veno-venous hemodiafiltration, it helps in removal of all kinds of solutes, whether it be small, medium, or large, and it is based on the principle of diffusion and convection. And so this is considered as the highest modality for treatment of CNI. Now, for the performance of dialysis, there are few determinants which are important. One is the flux. Second is the mass transfer area coefficient. Third is the urea kinetic modeling, which comprises of the urea reduction ratio and Kp by V. So if we come to the flux is basically quite similar to the ultrafiltration coefficient. It refers to the permeability of the membrane. It refers to the volume of fluid or solute that gets transferred per unit surface area of membrane per unit time. So during diffusion, the solute flux is basically driven by the Fick's law of principle. That is, it is dependent on the concentration gradient on both sides of the semi-permeable membrane. It is dependent on the temperature gradient. It is dependent on the diffusion coefficient and also thickness of the membrane. On the other hand, during convection, the solute flux depends on the membrane permeability coefficient as well as the transmembrane pressure. But nowadays, flux is not only confined to the ultrafiltration coefficient according to fluid. It has been broadened. The definition has been broadened according to beta-2 microglobulin clearance and beta-2 microglobulin sieving coefficient, as it is a large molecule. So if we consider the low flux molecule dialyzers, here the beta-2 microglobulin clearance is up to 10 milliliter per minute. Whereas high flux dialyzers, their beta-2 microglobulin clearance is more than 20 milliliter per minute. In case of high flux dialyzers, the beta-2 microglobulin sieving coefficient is 0.6 or above. If a sieving coefficient is equivalent to 0, that means none of the solute is permeable. If it is 1, that means it is permeable to the solute. So it is intermediate. So ultrafiltration coefficient in case of low flux dialyzer is up to 10 milliliter per hour per millimeter mercury. Whereas in case of high flux, it is more or equal to 20 milliliter per hour per millimeter mercury. And in case of low flux dialyzer, membrane pore size is 1.3 to 1.8 nanometer, whereas high flux dialyzer is 3.3 nanometer. So we also have a middle flux dialyzer, which actually is an intermediate between the low flux and the high flux dialyzer.
I would interrupt Chandrima.
Yes.
Maybe I would ask Swatarupa to give us a little bit of explanation or maybe a little bit of understanding that why do we need different types of flux? And this is quite common when our technician brothers and sisters, they come up with an, and they choose certain flux. Because if you see that obviously the high flux would be much more useful, right? Because they would be removing a lot of. So why do we choose? Why do we need to have low flux and middle flux? So Tarupa, a little bit.
Yes,
I'm
sir.
informed. Yep.
Yeah. So in dialysis, there are two basic characteristics that you have to understand. One is what is efficiency and what is flux. Flux means there is better permeability of molecules, which we call as middle molecules and large molecules. Whereas what is efficiency? Efficiency means there is better clearance of small molecules. Now, when does this difference come into importance? This difference comes into importance when you have a molecule that is getting built up in your system and which is of the category of either a middle molecule or a large molecule. For example, in our nephrology practice, the most common setting is a patient who is on dialysis for a prolonged time, for example, 4 years, 5 years, 10 years, and they develop increased amounts of beta-2 microglobulin. Now, beta-2 microglobulin is a molecule which is classically known as middle molecule. So the middle molecules, they are not usually dialyzed by the dialyzers that we use in our routine maintenance dialysis. To specifically dialyze the beta-2 microglobulin, you need a high flux dialysis. What are the other scenarios where we want a high flux dialysis is when you want to dialyze and get out certain toxins from the body, in certain cases of poisonings where the molecules are larger in size, and also in cases of multiple myeloma, where there is amyloidosis or there is increased beta-2 microglobulin in that area as well, where the size of the molecule is increased, and there you will have to use a high flux dialyzer to achieve better clearance. So the crux of the situation is what kind of molecules do you want to dialyze? If you're dealing with a patient with azotemia, uremia, you're dealing with increased urea, increased creatinine, these are small molecules. Small molecules means the size is less than 500 daltons. Urea is 63, creatinine is around 110 daltons. So these are efficiently cleared by the dialyzers that we use. But if you're trying to dialyze a patient of chronic hemodialysis or amyloidosis, where the molecules are middle molecules or larger molecules, then you will have to use a dialyzer which has got a high flux. So high flux means the pores of the dialyzer membranes are bigger in size, whereas high efficiency means there are pores, but small pores, there are numerous pores and the membranes are thin and it has got a high surface area. So numerous pores, high surface area correlates with high efficiency, whereas larger pores correlate with high flux. So that in a nutshell is the
very well explained. So can I also say that the fallout of a higher flux would be that there could be loss of some important molecules?
Exactly. So yes, so if you see at this slide, so middle flux will be, if we see that middle flux is an intermediate between low and high flux, so middle flux will be removing the middle molecules, which are the abnormal molecules that we target, like beta-2 microglobulin, but it will also remove vitamin B12 because that vitamin B12 size is kind of similar to beta-2 microglobulin. Hence, we see a lot of vitamin B12 deficiency in this group of patients. Whereas if you use high flux, then definitely it will cause loss of albumin and other proteins of the body system, because albumin is of the nature of 67 kilodaltons. It is a large molecule, and this will not be removed in low flux. This will not be removed in middle flux, but in high flux dialysis, you will get hypoalbuminemia, which you will have to correct with IV supplementation then. So there are advantages as well as disadvantages. Another thing, there's another prerequisite. If you want to use high flux, then there's a prerequisite. Chandrima, can you guess what can be the prerequisite of having a high flux dialyzer? What, like if you want to high flux, you cannot out of the blue use a high flux dialyzer. You need to have certain characteristics available to you. Only then you can use the high flux dialyzer.
Okay, we'll come to that. I think she has got something in the day. And to inform all you guys that we will have a separate lecture on how to select a filter, right? How to optimize it. But to understand in a very basic way, that for standard regular dialysis for CKD patient, you should use a low flux unless you are suspecting some accumulation of beta 2 microglobulin
In
and
chronic
intermittently
hemodialysis
running.
patients, then
Yes.
there is a particular indication. Yes.
And if you are using it as an extracorporeal toxin removals, there are specific high flux dialyzers in, as well as you have some sort of adsorbents also. We will have a different 2-3 lectures on that, so don't worry. But for chronic patient, if you are thinking of accumulation of middle molecules like beta 2 microglobulin or amyloidosis are there, you should use a middle to high flux. And for sepsis or inflammatory process in an acute patient, you should use middle to high flux, because most of our cytokines fall into the range of middle molecules. So that's why you need to have a clear understanding of the flux concept of the dialysis filter, so that you can choose the appropriate filter according to the clinical situation. Chandrima, please continue.
So next is the mass transfer area coefficient, which is also represented by the K0A of a solute. Now, K0A is usually the product of two quantities. One is the permeability coefficient of the dialyzer membrane for a given solute. Second is the total effective surface area of the membrane in the dialyzer. So it is defined as the theoretical maximum clearance of a dialyzer for a given solute for infinite blood and dialysis flow rate. So as it is dependent on the surface area, if we increase the surface area, the K0A will increase. If we make the membrane thinner, or if we adjust the porosity, K0A will increase. If we optimize the fluid path of dialysis in the dialyzer, K0A will increase. So nowadays, most dialyzers that we use have K0A values of less of 800 to 1600. But low efficiency dialyzers are usually with K0A value of less than 500, and high efficiency dialyzer usually with K0A value greater than 1600. The next one is to determine the adequacy of dialysis. There is an entity called urea kinetic modeling. Why we consider urea as a marker of dialysis is, one is it is a very low molecular weight substance. It is only its molecular weight is only 60 Daltons. It is easily distributed throughout the body water. Second, it is cheap and simple to measure. Serum urea concentration has been found to correlate well with symptoms and signs of renal failure. Urea concentration is also directly related to the protein catabolic rate, and it represents the balance between protein catabolism and clearance. And lastly, it is easily dialyzed. So how we calculate the urea reduction ratio? It is usually calculated as pre-dialysis urea minus post-dialysis urea divided by pre-dialysis urea into 100. So if pre-dialysis urea is equal to 100 milligram per deciliter and post-HD urea is 40, so we'll find the urea reduction ratio of around 0.6 into 100, that is 60%. For better dialysis, at least the urea reduction ratio should be more than 65%. Next is the KT by V. It is a concept which was introduced by Gauss and Sargent in 1985. So many publications have shown the association of KT by V with mortality. So what is KT by V? K is equal to urea clearance of dialyzer, which is mainly marked by milliliter per minute or liter per hour. It depends on the surface area of dialyzer, porosity of dialyzer, blood flow through the circuit, dialysate flow through the circuit, as it maintains the concentration gradient. Next is T represents the time of dialysis in minutes, and V is the volume of distribution of urea in the body. So how do we calculate KT by V? So if we consider the dialyzer clearance to be around 300 milliliter per minute. That is, K is equal to 300 milliliter per minute. Patient weight is 70 kg and time is 3 hours. Now this 3 hours we have to convert in minutes. So 3 hours is equivalent to 180 minutes. So if we multiply K into P, so it becomes around 300 into 180, that is 54,000 milliliters or 54 liters. So this is the value of KT, 54 liters, and it is referred to as the intensity of dialysis. Now our body percentage of water is about 60% by weight. So if a patient's weight is 70 kg, so the percentage of volume of distribution of urea comes around 42 liters. That is 70 into 60% of 70, that is coming around 42 liters. So now if I divide KT by V, it is coming around 54 by 42, which is 1.3 liters. Now, according to researches, if KT by V value is around 1 to 1.2, it shows that it is an adequate dialysis. And if the KT by V value is less than 0.8, it has been shown to be associated with increased mortality and inadequate dialysis.
Okay, Chandrima, at this point, I would like to just ask you, it is very well delineated, perfectly all right, the way you calculate the KT by V. But for example, just imagine a patient who's, you imagine this patient of 70 kgs, right? But what if this patient had edema? And the patient had, I will tell you exactly, this 70 kg is his edema free weight. And what if he had 3 kgs of edema also in him? Then how will you calculate V in that scenario?
Ma'am, if we consider the weight of the patient, like there is also this one.
So in the, so you have to understand what is V. So can you go back to the previous slide?
Yes.
So V is the volume of distribution of urea. Okay, next slide, sorry. Yeah, so V is the volume of distribution of urea. In the actual body weight, you will have to take 60% in the case of male. In a case of female, you will have to take 50% to get the total body water, right? But if the patient has got 3 kgs of edema, which is quite common with our dialysis population, when they come to us, they will come 3 kgs above their weight, and you will have to make them negative by 3 kgs further. So then that V calculation differs. In that, you will not only, you will take 60% of 70 kgs, but 100% of 3 kgs. Why? Because the edema fluid adds to the total body water in its entirety, meaning that 3 kgs of edema is just water. Okay. Our entire body is not water, only 60% is total body water, but the 3 kgs of edema fluid is entirely water. So that will be 60% of 70 kgs will be 42 plus additional 3, which will become to as 45 liters. 45. So that's another practical tip that I wanted to discuss. Okay, carry on.
Okay. So there is another logarithm of KT by V also, which considers the post-dialysis and pre-dialysis BUN, and also ultrafiltration volume in liters and post-dialysis weight in kg. So this can also be another form of calculation for KT by V. Now, if we see the comparison of KT by V with urea reduction ratio, so with the increase in KT by V, we'll find that there is an exponential fall in urea concentration, which establishes the logarithmic relationship of KT by V with urea reduction ratio. Also, according to researchers, this was a research performed by Jens Strand in 1997. He found that KT by V is associated with increased mortality. So with the increase in KT by V, the relative risk of death used to decrease. If the KT by V is around 1, the relative risk of death is around 5. But with the increase in KT by V, the relative risk of death decreased. There is another thing actually. There are a few causes which can lead to erroneous values of KT by V. One is if there is lower blood flow. than prescribed because of poor vascular access, or if there is some access recirculation, that is, if there is any venous stenosis, there may be turbulent flow across the circulation, and blood may go from the venous line to the arterial line. And in that case, there may be an erroneous calculation of KT by V. If there is decreased time on dialysis, it also leads to lower KT by V. If the dialysis, if there is clotting in the dialysis, it can also lead to lower KT by V. If there is error in blood sampling, then also it can lead to lower KT by V. There is another thing is even the equation that we use, it is based on a single pool model. But post dialysis, we have seen that there is often a rise in urea as the urea gets transferred from the intracellular compartment to the extracellular cellular compartment post dialysis. So this may lead to a lower value of KT by V sometimes, and so to consider this double pool, we have to consider an equilibrated form of KT by V rather than the specific KT by V. So the take-home message is basically diffusion follows a concentration gradient, whereas convection follows a transmembrane pressure gradient. Diffusion depends on molecular weight of the solute, whereas convection is independent of it. In hemodialysis, diffusion is typical, whereas convection is typical of hemofiltration. Now, high flux dialyzers may help in effective dialysis, but they can lead to some pyrogen reaction, and as bacteria can easily enter into the patient's bloodstream due to presence of large molecules, and there may be loss of some important molecules as well. For effective dialysis, urea reduction ratio should be above 65%, and KT by V should be at least 1 to 1.2. And we have found some researches which show an association of KT by V with mortality. Thank you.
Okay, Chandrika, very good presentation. Nicely
you,
made.
ma'am.
I have a few questions for you. You said about calculation of URR. So how will you collect the pre-dialysis and post-dialysis blood sample?
Yes, ma'am. Actually, I read a few books. One said that the post-dialysis BUN should be collected 30 minutes after the dialysis, because by the end of 30 minutes, equilibration gets complete between the intracellular and extracellular.
Before the end of dialysis, you will calculate that 30 minutes before the end of dialysis. That is number one. What else will you do? So you will have to decrease. You have to stop ultrafiltration and also decrease your blood flow to 100 for 15 seconds. And why do we do this? Because there's at this low blood flow, there is a chance of excess recirculation. To negate that, we collect the post-dialysis blood 30 minutes from the end of the session after stopping ultrafiltration and after decreasing blood flow to 100 for 15 seconds. That is how you calculate the post-dialysis BUN sample. And pre-dialysis BUN sample is easy. You collect it before the start of dialysis, from the arterial port.
Arterial port.
Of the arterial port. That is important to remember. Okay. And can you tell me what is the relationship of URR and KT by V? Now we have both this value, both these methods by which we can assess adequacy. So what is the relation between URR and KT by V, and which one should we prefer? Is there any preference?
Ma'am, there is a logarithmic relation between KT by V and URR. That is, KT by V is equal to minus ln into minus logarithm of 1 minus URR.
So what URR is, it is a marker of urea removal. But what KT by V in addition gives you, if you can go back to that Doggy-Das equation.
Yes.
No, previously, a few slides. So over here, you will find that in KT by V, when you're doing ultrafiltration, you are using the principle of convection. Okay. Urea reduction is reduction of urea. Over there, you will get only the diffusive clearance. You will not get the convective clearance. Understood? But in KT by V, if you use this particular formula, then you are getting the convective as well as the diffusive clearance. Okay. The R coefficient over here is actually the urea. In addition to R, what else are you getting? This UF by W, this will give you the convective clearance that is happening when you are doing ultrafiltration. What else? The middle part of the equation, 4 minus 3.5 into R. What does this denote? This denotes the urea generation. For example, within the 4 hours or 5 hours of dialysis that we do, there is urea generation in the body, which is not taken into account in the URR equation. But these are the two things that KT by V will help you in better estimating the actual delivered dialysis dose. One is it accounts for the urea generation, which happens during dialysis. And second is it also accounts for the convective clearance. So URR by versus KT by V, KT by V is definitely a better and a more logical marker for dialysis adequacy. But as you can see, it is a bit difficult to calculate on the grounds. If you have an urgent critical patient and you have a lot of stuff to do, then you can just go by URR. URR is not that a bad parameter, but just remember that it has these two downfalls. Okay. Carry on.
Okay.
No, I think she finished off. Swatha, how do we calculate? This is a mathematical difficult logarithmic calculation. Does our modern machines give away the values itself, or we have to?
So there are certain machines which give you these values, but if you have these parameters in your hand, you can calculate. There are calculators. There's an dialysis adequacy calculator. It comes by this name only. You can search it in Google. Okay. You need this basically this formula. You need these parameters: the post dialysis BUN, pre dialysis BUN. You have to give the ultrafiltration volume in liters, the post dialysis weight in kgs, and also T. T has to be given within minutes. So if you just put in this formula, you will get the automatic KT by V calculated.
Okay. And you asked that your 3 kg extra fluid.
Yeah.
So how do you calculate that 3 kg extra? Is it according to your BCM?
Yeah, so there is a concept of dry weight in dialysis. So dry weight is the weight of hemodialysis patients, where ideally they should not be requiring any antihypertensives. There should be no sign of either hypervolemia or hypovolemia. So this is a theoretical concept. By a trial and error method, when we are starting dialysis, we come to a dry weight. We establish this as a dry weight, where the antihypertensive requirement is less. The patient does not have any kind of fluid retention and is also not suffering any signs of hypovolemia, for example, muscle cramps. So this is the dry weight that we establish for one patient. And the next time the patient comes for dialysis, for example, if we have decided on 50 kgs, the next time when he comes with a weight of 52 kgs, then the edema is of 2 kgs. That is how we calculate for our maintenance hemodialysis patients. Okay. Now, calculating this dry weight is not an exact science. This is as I said, by a trial and error method. Some patients can appear absolutely clinically dry, but they can have this persistent symptoms of orthopnea, PND. And then you will have to think that, okay, I will have to go down, probe my dry weight further. And by this trial and error method, we actually...
But does it apply then for acute patients or a AKI patient who is going for a first-time dialysis or something?
No. So that discussion or the entire part that Chandrima covered right now is for maintenance intermittent hemodialysis, when we have a quasi-stable condition. It is not for our AKI, for our critically ill patients. The reason why it is important to know this, because this is the stepping stone. Chronic hemodialysis is easier to understand than acute hemodialysis. And if you don't understand these principles, it will be difficult to cover up to understand what Reshma is going to teach us in the next segment. And also,
I think then we'll wait for that and we'll take this question. Okay. So should we invite Reshma to cover the next part? Okay. Dr. Reshma, are you ready?
Yes, sir. I need to share my screen.
Okay. So I think Chandrima, you can log off from the screen. And yeah. But be with us.
Yes, ma'am. Where are you?
Right.
Arindam, really?
Yes, sir.
Yeah.
Sudhir sir has joined. Sir, please.
No, I've listened to from the beginning itself. It was an excellent presentation by Chandrika. And the inputs
Thank
by
you, sir.
Satrupa is really marvelous. Okay. So wanted to just emphasize certain points. Whenever you are calculating, like one is high flux versus the low flux membrane. So as you asked the question rightly that why we want to use the low flux then or intermediate flux, why
Yes, sir.
not give all the patients should be dialyzed on high flux membrane where we clearance will be better, middle molecule clearance will be better. So cytokine removal will be better. So in conventional hemodialysis patients like uh, maintenance hemodialysis, uh, what we have seen in evidence, certain other trials which we have done, the largest possible trial was HEMO study, which said that just changing the modality from high flux dialyzer to low flux dialyzer, actually the benefit is not much. The second one is there is a curious phenomenon happened which led to HEMO study. That is in USA. When we knew that the patient, the high flux dialyzer clearance are more, with middle molecule clearance, even the phosphate clearance is more, which is a middle molecule. So people try to start using high flux membrane. However, this KT upon V, what we are calculating right now of 1.3 or more than 1.2, you can achieve with shorter duration of dialysis as well. Let us say that with conventional dialyzer, we are giving 4 hours of dialysis and we are achieving the KT upon V of 1.3 in 4 hours. Whereas if you use high flux dialyzer, then in 3 hours, probably you can achieve that KT upon V goal of 1.3.
Right, sir.
So then the practice went like this, since it was a insurance driven setup in USA. So all the hospital and the hemodialysis centers started giving 3 hours of dialysis and use high flux membrane. Then after some period of time, the effect of inadequate dialysis set in. Although the flux was important, but the duration is also important. You cannot actually clear the solutes which might be middle molecule, which might be something uremic toxins which we don't measure. That is also getting cleared, and when it has been seen that longer the duration of dialysis, you are able to filter out the middle molecules more. And that too we can expect from the intermediate flux dialysis also. So that's why, again, there was after this hemo study, the switch happened that no, we should not be compromising on time. We should be giving 4 hours of dialysis to each and every individual. And we have to achieve that goal of 1.2. However, in hemo study, they have seen that more the number, like if let us say that you want to give KT upon V dose of around 1.5, then they compared these two group of patients where you are delivering more than 1.2 and those who are getting 1.35. And we thought that probably they will fare better, but that was not seen in that evidence. So it is a little bit complicated story. In this year, I don't know whether everybody could understand this or not.
No, sir, agreed. That is exactly how it came by and very well described, sir.
Then other thing which has been discussed, which has not been discussed here, is this formula of Daguridas versus the URR. Okay.
Yes, yes.
So I think briefly, Satrupa has given a hint about that. There are more to it, but you have to keep it in mind that at least you should have 3 times a week dialysis. That is the hypothesis generated by Daguridas, that unless until you have 3 times a week dialysis of 4 hours or more duration, then only you should consider having this KT upon V calculated in long run to see whether adequate dialysis has been given or not. Now, in practicality, in acute care setting, if you say that let us try with KT upon V, how much is it? So in that scenario, you are giving everyday dialysis or almost 4 to 5 times a week dialysis. Then this formula which has been given to us by Daguridas is not valid. Okay, or the patient who are having twice a week dialysis or once a week dialysis, this Daguridas formula doesn't give any information. And we cannot say at that point of time that the KT upon V we have achieved, so we have given adequate dialysis. It is not true. So the minimum criteria for calculating this KT upon V is that you should have more than 3 times a week dialysis. Recently, there is a modification by Daguridas again, looking into the more frequent hemodialysis pattern. There are few centers who are giving frequent nocturnal hemodialysis, where the people used to come, get the hemodialysis for 5 days a week or 4 days a week or 6 days a week, and then get dialyzed and then subsequently go home. So this formula will not hold true in that scenario. So he modified it, and there is a modified Daguridas formula for that scenario as well, which has been in recent dialysis handbook of dialysis. It has been given. So these are 2 points which I wanted to emphasize. Besides Satrupa, which
Okay, so Reshma, you can carry on. I think I would ask all our critical care friends to go back and read the handbook of dialysis and clear the concept of KT by V. Maybe a little new to all of you, but it's quite simplifiedly explained. And also this is a foundation of our understanding for the subsequent lectures. So over to you, Reshma.
Thank you, sir. So I'll be moving forward. So just to brief on what are the goals of RRT, it is mainly to maintain fluid and electrolyte, acid-base and uremic solute homeostasis, to facilitate additional supportive measures, that is enable the delivery of antimicrobials or other vital medications, nutrition supports and multiple blood transfusions, to prevent additional or worsening of the non-renal organ dysfunction that may have been attributed to by the acute kidney injury, to facilitate the renal recovery, to help avoid further insults to the kidney, and to improve patient outcomes. But what are the drawbacks? There can be iatrogenic episodes of hemodynamic instability, which may impede the kidney repair and recovery. Procedure-related complications that can be bleeding, thrombosis, CRBSI, pneumothorax, uncertain clearance of micronutrients, trace elements, and subtherapeutic levels of antimicrobials or antiepileptics. There can be unnecessary exposure to few patients to RRT, who probably might just spontaneously recover. There's a possibility of spontaneous recovery of the kidney function with conservative management, need for immobilization, use of health resources, and increased health care costs. So what can be the triggers for starting RRT? It's not a single value, but the trajectories that can be seen for few lab values, few clinical factors, and patient preferences. So the absolute indications are when there is refractory rapidly rising hyperkalemia, which is more than 6.5 millimole per liter, refractory metabolic acidosis with pH around less than 7.2, refractory pulmonary edema, which is unresponsive to diuretics, complications which are attributable to uremia, that can be encephalopathy, pericarditis, and coagulopathy, and in poisoning cases or drug overdose. There are a few relative indications also where there is limited physiological reserve to tolerate the consequences of AKI with patients already known case of advanced kidney disease, advanced non-renal organ dysfunction, intolerant to excessive fluid accumulation like we see in patients with impaired cardiac function, anticipated solute burden like in cases of rhabdomyolysis, tumor lysis syndrome, need for large fluid administration, that is nutrition support, medicines, or multiple blood transfusions, severity of the underlying disease, which may affect the likelihood of recovery of the kidney function, and cases of poisons or toxic drug overdose, which can be removed by renal replacement therapy, that is salicylates, methanol, metformin. So I would like to include few trials. That's the START AKI trial. That's the standard versus accelerated initiation of renal replacement therapy in acute kidney injury, where 3,019 critically ill patients with severe AKI were taken. So they were divided into early strategy and the late one. Early strategy, which means that within 12 hours of identification, they had started RRT, whereas the delayed strategy was once the indications, like we saw, once the indications were found out, then they started the RRT. So at the time of randomization, mean serum creatinine was around 3.5. Potassium was 4.5, bicarbs 19.6, urine output around 460 ml per 24 hours, and 45% patients were oliguric or anuric. So RRT was initiated in 97% patients, which randomized to early strategy as compared with 62% patients assigned to the delayed strategy. They found that there was no mortality difference at the end of 90 days. However, early strategy patients were more likely to remain RRT dependent at the end of 90 days and required rehospitalization. The adverse events were common and there was no improvement in outcomes with the early strategy group. There was AKIKI 2 trial, that's artificial kidney initiation for acute kidney injury, where 278 critically ill patients with severe AKI, these patients were included who did not have any urgent indications for renal replacement therapy. They were monitored for oliguria for almost 72 hours durations, or there was an elevation in BUN for around 112 to 140 milligram per deciliter. But they found out that there was no difference in the number of days alive and free of renal replacement therapy between this randomization and 28th day. At the end of 28 days and 60 days, the mortality was higher in the group who had RRT deferred, though it was not statistically significant. There are a few acronyms that we need to know. That VV means veno-venous. Hemofiltration would be conveyed as H, hemodialysis as HD, hemodiafiltration as HDF, and CVV HDF means continuous veno-venous hemodiafiltration. So a bit difference between intermittent dialysis versus the continuous. So the concentration of gradients of solute between the blood and dialysate leads to the desired biochemical changes. In order to prevent the filtration of the dialysate getting back into the bloodstream, this compartment is under negative pressure related to the blood compartment. So relatively higher blood flows are used in intermittent hemodialysis. That's around 200 to 400 ml per minute, which is coupled with the dialysate flow rates to almost double of it. That's around 500 to 800 ml per minute. Now, this enables the high solute clearance rates over a relative short period of time. So this may be associated with complications in the critically ill patient. So how do we minimize these adverse hemodynamic effects? We limit the maximal blood flow to around 150 ml per minute with a minimal session at least of around 4 hours. Simultaneous connection of the circuit with a catheter that is primed with normal saline. Setting the dialysate sodium concentration more than 145 millimoles per liter. The dialysate temperature should be around less than 37 with cooling to 35 in hemodynamically unstable patients, and commencing the session with dialysis for a short period followed by ultrafiltration. A few lines about various modes. That is CVVH, where the solute transport is achieved predominantly by convection utilizing a high flux membrane. It produces an ultrafiltrate which is replaced by a substitution fluid, with volume balance being achieved by the degree of replacement. So this replacement fluid may be infused before or after the filter. Whereas in CVVHD, the process is driven by a veno-venous pump through an extracorporeal circuit through a hemodialyzer containing a semi-permeable membrane, where there is adequate exchange of small molecular weight solutes into the dialysate, and hence they are removed. So in general, hemodialysis is effective for removal of small molecular weight solutes and becomes increasingly less efficient as the molecular weight rises above 1,000 Daltons. Now CVVHDF, this combines two processes of diffusion and convection by introducing a counter current flow of the dialysate into the non-blood containing compartment of the hemodiafilter. This theoretically increases the efficiency of clearance of smaller molecular weight solutes over that of the hemofiltration without dialysis. So this was originally introduced to increase the limited clearance of urea and other small molecular weight solutes in arterial driven hemofiltration systems. So the different types of RRT, that's the intermittent hemodialysis, continuous hemodialysis, then CVHD, that's the hemofiltration, and HDF, that's the hemodiafiltration. So in intermittent hemodialysis, to start with, we can set a blood flow of around 200 to 400 ml per minute with a dialysate flow of around 500 to 800 ml per minute. And the methodology that the dialysis occurs is through diffusion, mainly through diffusion method. Similarly, in continuous hemodialysis is also through diffusion method, but the blood flow and dialysate flow rates are lesser. The blood flow is around 80 to 150 ml per minute, whereas the dialysate flow is around 10 to 35 ml per minute. Whereas in continuous veno-venous hemofiltration, the blood flow is around 150 to 250 ml per minute with a filtration rate of around 25 to 50 ml per minute, and the mode of filtration is through convection. And HDF is a combination of diffusion and convection. So the dialysate flow is around 10 to 35 ml per minute, and filtration rate is around 10 to 50 ml per minute, where we keep the blood flow as 100 to between 100 to, we start with around 100 ml per minute and can go up to 250 ml per minute. And the mode of filtration is both convection and diffusion. So there's this hemodiaf study, which was a prospective multi-center French study where they included 360 patients with AKI and multi-organ dysfunction syndrome. They were randomly assigned to intermittent hemodialysis or CVVHDF. So the primary endpoint was the survival at 60 days. Now the severity of illness was similar in both the randomized groups, and the protocol adherence was good. Both groups used the same dialysis membranes, and there was a low rate of crossover from intermittent to continuous therapies. So at the end of 60 days, survival was the same in both the groups. And in addition, both the therapies were associated with similar rates of hypotension, including the group of hemodynamically unstable patients. And most importantly, the mean duration of the hemodialysis treatments were longer than that was typically employed in US. That's around 5.5 hours is what they are done. So this study also demonstrates that it is possible to successfully perform intermittent hemodialysis in practically all patients with AKI, given the findings of similar hypotensive rates with stable and unstable patients, and the low crossover rate from intermittent to continuous therapy. There was another trial, that is CONVINT trial, that's continuous versus intermittent hemodialysis in ICU patients. This was a single center randomized controlled trial of 252 critically ill patients. This was conducted in Germany, where these patients were randomly assigned to CVVH, that's the hemofiltration, at a prescribed dose of 35 ml per kg per hour or daily hemodialysis. 19.5% of the 128 patients were randomized to intermittent hemodialysis was switched to CVVH after a mean of around 4.4 plus days because of severe hypotension or volume management, while 45.9% patients randomized to CVVH was switched to IHD after a mean of around 6.2 days because of repeated filter clotting, bleeding necessitating discontinuation of the anticoagulation, metabolic control, thrombocytopenia, overall improvement in overall status, and need for mobilization. So the survival 14 days after discontinuation of RRT was around 39.5% in the intermittent hemodialysis group, as compared with the 43.9% in the CVVH group. There was no difference in the in-hospital mortality or 30-day mortality at follow-up. There was no difference either in the recovery of the kidney function also. So a word about hybrid techniques. It's also called as PIRRT, that is prolonged intermittent renal replacement therapy. It's on a daily basis. The different forms are SLED, that's sustained low efficiency daily dialysis, SLED-F, that is diafiltration, extended daily dialysis, that is EDD, and EDD-F, that's extended daily dialysis with the filtration. So the advantages of these techniques are because of the logistics, because of the cost, it minimizes the hemodynamic instability, there are lower anticoagulant needs, and the patient mobility is improved. So what's the optimal dosing? So the dose of RRT is a measure of quantity of the solute that is removed from the patient during extracorporeal treatment and is reasonably the representative of other solutes which require removal. In patients on chronic hemodialysis, the dose of treatment is expressed as KT by V and or URR. So both the parameters have important limitations in critically ill patients with AKI, where neither the urea generation rate nor the volume of distribution can be clearly defined. So in intermittent hemodialysis, the dosing depends upon the dose delivered per session and the frequency of sessions. Alterations in the dose per session as well as in the dialysis schedule can be evaluated. No studies that prospectively evaluated the impact of differences in the dose per session in patients undergoing intermittent hemodialysis on a fixed schedule. In CRRT, the clearance of small uncharged molecules such as urea and creatinine is equal to the delivered effluent rate. So the effluent rate roughly corresponds to the prescribed replacement or dialysis rate, and it is often used as a surrogate of urea clearance. The effluent flow rate is roughly set around 20 to 25 ml per kg per hour. Increasing the dose beyond this number has not been shown to be beneficial and may potentially result in losses of important solutes, including phosphate, antibiotics, and heat. So in a pre-dilution mode, the target dose should be increased to around 25 to 30 ml per kg per hour in order to achieve a delivered dose of 20 to 85 ml per kg per hour. So the degree of pre-dilution and filter down time are important factors which reduces the effective dose. The infusion of replacement solution as pre-dilution, it will reduce the effective effluent dose by the degree to which the plasma is diluted. So the final dilution effect is dependent on the circuit blood flow, replacement fluid rate, and the hematocrit. Premature circuit clotting or need for investigations outside the ICU are common reasons for these for the unintended interruptions in the treatment, which can lead to reduced clearance. Now, effluent rate only represents a clearance of small solutes, but not the larger molecules or molecules with high protein binding. In addition, other important aspects of RRT that is to be considered when prescribing a dose is the acid-base homeostasis, nutritional support, and the fluid balance. So there is this study, that is VA NIH ATN study, where 124 patients were treated with various forms of dialysis based upon their hemodynamic status. So they were randomly assigned to one of the two dosing arms, that is the intensive therapy and less intensive therapy. So in intensive therapy, they had this hemodialysis and the prolonged intermittent PIKRT type of dialysis, which was given 6 times per week with a target of KT by V of around 1.2 to 1.4 per treatment. Whereas CRRT was provided with an effluent flow rate of around 35 ml per kg per hour. This was the intensive therapy. Whereas a less intensive therapy, the cycles were given 3 times per week with a target of KT by V of around 1.2 to 1.4 per treatment, while the CRRT was provided with a flow rate of 20 ml per kg per hour. The death rate at day 60 was the same for both the groups. That was around 53.6% for the intensive therapy and 51.5% for the less intensive therapy. And in addition, the duration of the RRT and the rates of recovery of the kidney function or other organ failure was similar for both the treatment arms. So the group that received intensive therapy had an increased number of hypotensive episodes. Thus, more intensive therapy beyond that obtained with a standard thrice weekly regimen with a target KTV of around 1.2 to 1.4 per treatment, or a standard CRRT with an effluent rate of 20 ml per kg per hour does not improve the clinical outcomes. There was another study called as a renal study, which was a trial in Australia and New Zealand, where they included 1,508 patients with AKI who were randomly assigned to CVV HDF with an effluent flow of either 25 or 40 ml per kg per hour. At the end of 90 days, the mortality was the same in each group. In addition, the incidence of patients who continued to receive RRT at 90 days was similar with both the dialysis doses. That's 6.8 and 4.4% of higher and lower intensity groups. The application of high volume hemofiltration in severe sepsis and septic shock is not recommended based on the results of human studies. Drug clearance, including antibiotics, is affected by high dose CRRT and may potentially lead to subtherapeutic drug levels, resulting in the treatment failure. Just a slide about dialysis disequilibrium syndrome, which occurs because of rapid removal of urea during dialysis. This is a phenomenon that occurs because of dysfunction of the CNS, which is attributed to cerebral edema, which occurs during or just after the renal replacement therapy. There is increased urea removal from the plasma over that compared to that of the CSF, resulting in movement of water into the brain. So the symptoms would be nausea, headache, vomiting, tremors, seizures, that's altered mental status. So there's no particular treatment for the same, but we can prevent this by having shorter sessions of the dialysis, lower blood flow rates, and use of smaller surface area filters. So to conclude my talk, just a small chart when there is AKI and presence of life-threatening complications of AKI are there, which can't be reversed by conservative management, then we need to think about RRT. In the meanwhile, reverse hypovolemia, optimize hemodynamic status, discontinue or avoid nephrotoxic drugs if possible, and regular assessment of the clinical status, which includes acidosis, fluid balance, severity illness, and the initial response to resuscitation. Depending on that, we try to assess the need for RRT. If any of these, indications, that is the hyperkalemia, acidosis, worsening oliguria or non-renal organ dysfunction, significant fluid or solute burden is more. If any of these indications are there, then we definitely switch over to RRT. But if not, then we again go back to reversing the hypovolemia or optimizing the hemodynamics, regular assessment of the clinical status, which includes the acidosis and lab parameters. In intermittent hemodialysis, so we ensure a delivery of KT/V of more than or equal to 1.2 per treatment, which corresponds to the urea reduction ratio of more than 0.67. More frequent treatments may be necessary for volume management, or if the target delivered dose of therapy cannot be achieved. In CRRT, prescribed the effluent flow rate of 25 ml per kg per hour, so that the delivered effluent flow rate is around 20 ml per kg per hour, which is the sum of hemofiltration rate and the dialysate flow rate. That's all from my side.
Excellent presentation, Reshma. Thank you. So in conclusion, it is obviously we have all these modalities at our disposal. I just want to conclude by highlighting the importance of those hybrid therapies that you mentioned.
Yes.
Most number of times we are not able to afford, like patients are not able to afford this CRRT machines, the bags, the filters. So in all such cases, going for SLED is obviously a very good option. And all the trials that we have seen, that we discussed, that you discussed right now, there is no proven benefit of CRRT over these modalities. So I personally prefer going for this SLED or SLED-F whenever obviously CRRT is not an option. Over to you, Dr. Arindam, if you have any inputs.
Now, as of now, so we had, I think, covered most of the things. I was wondering that what our next in which parts we will detail. So I will discuss with you, Dr. Rushi and Dr. Das sir, so that we can come up with certain more interesting topics. But I would also request you and also my other nephrology friends who are in the group to come up with at least in a fortnight a couple of cases, so that it gets a little more interesting rather than only didactic lectures.
Yes,
So,
yes.
and if certain cases can be discussed, and we
Yep.
can, and it may not be completely very formal, but if you just can present one or two cases in a fortnight and at least alternating presentations, so that would be quite useful. And I would also say that please give your feedback, share. This is a very new group, very new concept. We are day by day increasing, trying to reach out and include more people. Is a completely free access platform. So feel free to add your friends, invite your friends to come up, because more the merrier, and more people will bring up an impetus and enthusiasm and collective wisdom. So that would be
I had a great
quite a
time
success.
today. Yeah, I had a great time today, and definitely we will continue this endeavor. It
Yes,
seems
okay.
very productive session.
Thank you. So we would be meeting next Thursday, same time, 7 p.m. Thank you and good night all.